Hello, my name is Kathy Kennett. I'm Vice President of Clinical Care for Parent Project Muscular Dystrophy. Welcome to the first of PPMD series of 3 pulmonary webinars. This webinar will last for approximately 60 minutes. All audience members are on mute. You may type in your questions in the box in the lower left side of your screen. If possible, we'll save all the questions for the end of the webinar. This webinar, as well as the questions and answers, will be archived on PPMD's website. It's now my pleasure to introduce today's Dr. Hemant Sawnani is board certified in both pediatric pulmonology and sleep medicine. His interests are respiratory control and respiratory mechanics. Working with the neuromuscular population conveniently marries those interests. The majority of his patient population include patients dependent on various breathing devices, both invasive and non-invasive. He is currently the point pulmonologist for the Comprehensive Neuromuscular Center at Cincinnati Children's Hospital Medical Center and cares for Duchenne patients participating in the ventricular assist device program. Hemant has both spoken and published in the areas of neuromuscular pulmonology. Dr. Oscar Henry Hank Meyer is an associate professor of clinical pediatrics at the Perelman School of Medicine at the University of Pennsylvania and an attending pulmonologist within the Division of Pulmonology at the Cincinnati Hospital of Philadelphia, CHOP. He is the medical director of CHOP's Pulmonary Function Testing Laboratory. He has broad clinical interests, including the pulmonary manifestations of neuromuscular disease, and is involved in furthering the field. He's led research, published, and has engaged in national and international committee work. Dr. Richard Schell is an assistant professor of pediatrics at the Center for Respiratory Health at Nationwide Children's Hospital in Columbus, Ohio. He is an active member of the neuromuscular team in Columbus, Ohio, and has been involved in multiple research studies involving neuromuscular population. He is an active participant in PPMD and Cure SMA. Before we begin, I would like to take just a minute to talk just briefly about Duchenne Connect. And as I'm sure you all know, Duchenne Connect is a patient-reported registry that's supported by PPMD. If you've not registered yourself or registered your child, please do. If you have registered, please go in and be careful to update you or your child's information annually. And just as a demonstration, I wanted to show some of the data that we've been able to collect from Duchenne Connect. And this data demonstrates why it's so important to keep this data updated. Very important for research and industry, and it's very important for care. So now I'd like to turn it over to Dr. Meyer, if you'd like to start the webinar.
Sure, thank you very much. Now, do I have control of the slides from my computer, or do I need to direct?
No, it looks like you were unable to get the presenter control. So, Kathy, will you be able to toggle through for Hank?
Sure, just let me know.
Great.
Okay. Well, thank you very much for the opportunity to speak, and I've been charged with discussing care related to acute illness and Duchenne muscular dystrophy. So I'd like to talk about 2 general categories in respiratory illness management. The first is some preventative management, and then I'm going to spend the vast majority of the next 10 to 15 minutes talking about some proactive management that can be done in the early stages of respiratory illness. Next slide, please. So for preventative management, a lot of this is borrowing from standard, pediatric care, and obviously that starts very much with maintaining the normal immunization schedule, including doing a seasonal influenza vaccination each year. In some neuromuscular conditions, there's a question about using the RSV vaccine, otherwise known as Synagis or Palivizumab, and there's really no data to support its use. Certainly nothing outside of the early infancy. Then there is another general category of preventative measures related to range of motion. And Dr. Sawnani has an active study related to this, and I believe we'll be talking some about this later on in the session. And so I won't talk about that. If there are further questions, we can certainly discuss those in great detail towards the end. So next slide, please. So for proactive management, I think it's important to follow the same principles that we would follow in general for treating an acute respiratory illness, and that is to really cough a lot and cough early, which is somewhat of a silly comment, but that's really what it gets down to. And to do that effectively in Duchenne muscular dystrophy, you need to start with ensuring that you have an effective cough. And then to the extent that that's not the case, then figure out a reasonable way of supporting an ineffective cough. Next slide, please. Next slide, please.
I did.
Oh, okay. Okay, so the act of coughing involves three separate phases. The first is taking a deep breath. It's an inspiratory phase. The idea behind that is to fill the lungs up completely and get air behind where the secretions are in the airway. The other thing is to optimize the what they call the length-tension relationship of the expiratory muscles, and that involves stretching the muscles as far as possible so that there's more potential contraction, and so that you can also utilize the elastic recoil of the muscles. And so the further you stretch the muscles of exhalation, the greater force they can apply in forced exhalation during coughing. The second phase is what they call the compressive phase, where you start to exhale, but you exhale for a brief period of time against a closed glottis or closed vocal cords. And after about a quarter of a second or less, the vocal cords will open, and then you'll get an explosive flow of air leaving the lungs. And this has been quantified by a gentleman named John Bach, who's a physiatrist that practices in northern New Jersey, and he found that if you have a forced expiratory flow during coughing of under 160 liters per minute, you will not have a productive cough. And in that situation, he has recommended doing assisted coughing maneuvers. And so many people will use this measurement, what they call the peak cough flow, as an assessment tool to determine when assisted coughing maneuvers are needed. Next slide, please. So I'd like to talk about different strategies for augmenting a weak cough. And there are three general ones and then an additional category. The first is helping with inspiration, so helping a patient breathe in more deeply. The second is helping with exhalation. And then the third is to augment both inspiration and exhalation. And then I'm going to talk about a couple of other options separate from augmenting the cough mechanism. Next slide, please. So for inspiratory assistance, for younger patients or less affected patients with muscular dystrophy, we can utilize the respiratory muscles by doing a technique called breath stacking, which I'll show on the next slide in just a moment. That involves placing a mask over the mouth with a one-way valve that allows a patient to breathe in and take a series of successive breaths in to raise their lung volume as far as possible to, as close as possible, approximate what a patient would be able to do by taking a deep breath. They then would exhale on their own with as much expiratory force as they can generate. There's a mechanical way of doing this using a technique called intermittent positive pressure breaths, which is usually shortened to the IPPD, and that involves using mechanical devices that I'll show in a couple slides. So if you go to the next slide, this should be a picture of an oral nasal mask, which is the setup that we use, and it has about 4 parts to it. If you look over on the right side, that's a one-way valve that allows air through in one direction, and then ideally the air will go in. The patient will breathe in until they can breathe in no further, and then they will pause for a moment, rest, and then breathe in a second time until they can't take any further breaths. And then at that point, they'll be coached to hold their breath for a moment. The mask will be removed, and then they will breathe out as forcefully as they can. we can move on to the next slide. A mechanical way of doing this is using a device that can apply a positive pressure, and the one that we use most commonly here in the U.S. is the cough assist. The most modern version, the T70, is pictured to the right. And the way you would do this is by applying a pressure that's set to what's comfortable and effective for the patient that allows them to breathe in as deeply as possible. The way we usually do this is by applying the pressure for about 1 to 2 seconds until the patient has clearly finished breathing in, and then we would remove the mask from the patient's mouth and then mouth and nose, and then coach them to exhale as hard as possible. So just replacing the inspiratory phase. Next slide, please. And so this is some data from a German group looking at a group or cohort of patients with a variety of different neuromuscular conditions, looking at the peak cough flow, which we had referred to a little bit earlier. And just as a review, the peak cough flow is abnormal if it's below 160, which would be almost halfway up the graph there. And so what this documents is that in using IPPD or inspiratory assistance, you can get a 69% improvement or a statistically significant increase in peak cough flow just by augmenting inspiration. Next slide, please. So I'd like to talk some about expiratory assistance, and that can be done in a variety of different ways. You can certainly provide expiratory assistance by compressing the chest wall. Then you can also separately compress the abdomen, or you can do both at the same time. And it kind of depends on your personal opinion about which way to go. I have an image in the next slide showing each of these maneuvers, and this is from a respiratory therapist, Michelle Toussaint from Belgium, who has really done a lot of wonderful work in this topic. And if you look at the top two images, that shows the patient at rest, and then down below in the bottom two images, it shows the patient on exhalation with just chest wall compression on the bottom left image, and then chest wall and abdominal compression in the right image. And both of these techniques can be helpful in exhalation. It really depends on what the patient, him or herself, tolerates the best and what seems to get the best expiratory flow. Next slide, please. So I'd like to talk about combining both of these maneuvers, and you can do this non-mechanically using breath stacking, as we talked about before, and then shifting very quickly to a manually assisted cough, as was demonstrated in the previous slide. Or what many do in the U.S. is using a mechanical device such as the cough assist. Next slide, please. So this is data from John Bach, who's the physiatrist I referred to earlier, who did work on peak cough flow. And he's really done a lot of tremendous work in utilizing the cough assist. And he actually really has been credited with bringing it out of mothballs, as it were, and making it a very viable device to use. And what this shows is this is data from 4 different conditions that can affect children. And obviously, you can see Duchenne muscular dystrophy at the top. And if we focus on that, what this shows is that in this group of 53 subjects who had a mean age of 26, so obviously well into adulthood, the mean peak cough flow before doing the cough assist was 1.58, where after with using augmented exhalation, the cough peak flow was over 2 times the flow, so over a 2-fold increase in peak cough flow, obviously demonstrating that you can substantially augment exhalation or cough efficacy. Next slide, please. So this is another study that came from Toussaint and colleagues looking at three different ways of coughing in a cohort of neuromuscular patients. The first is just asking a patient to be able to take a deep breath and breathe out as fully as they can, just an unassisted cough, which is in the diagram over in the far left column. And in that group, you can see the mean, which is that middle bar in that box, is well below 160 liters per minute. Whereas with just augmenting exhalation, which is in the second box and whisker plot, there is an increase that wasn't significant. You got about the same increase by just augmenting inspiration. That's in the third column. However, if you augment both inspiration and exhalation, you get a substantial increase in peak cough flow, which is in the rightmost column. Next slide, please. So this is our friend the cough assist, which I think many of us in the States use quite widely in doing augmenting exhalation. Next slide, please. The way we set this up is by cycling different pressures. And the pressures that we usually will use range from 15 to 50 centimeters of water with a hold on inspiration for about 1 to 2 seconds, and then shifting very quickly to exhalation of about the same pressure for about 1 to 2 seconds. Sometimes patients get a very strong sense of their upper airway collapsing during exhalation and do much better with a lower expiratory pressure, but that's really patient dependent. The protocol that we follow is to do 5 cycles of breathing in and breathing out, pause, allow the patient to expectorate whatever mucus may be present or help with suctioning, and then repeat that 4 additional times for 5 sets of 5 cycles of cough assist. Next slide, please. And this is data from Brigitte Furreau, who's a pulmonologist in Paris who's done a lot of work in looking at non-invasive ventilation and other ways of providing airway clearance. And it shows what you might expect, that as you provide more and more negative pressure more and more inspiratory pressure using the cough assist, that you can provide a higher and higher lung volume, and therefore set a patient up for being able to exhale a larger volume of air. Next slide, please. I want to move on and just very briefly talk about another way of doing airway clearance that in which there's some evidence of efficacy in neuromuscular disease, though not quite as much as the cough assist. And this is something called intrapulmonary percussive ventilation. And there's a device that's below, which is called the percussion air, which is available for home use. And what this device does is it provides nebulization under pressure with high-frequency oscillation. And the 3 of those things together, the applying a pressure to the airway opening helps to raise lung volume. The oscillation can help mobilize secretions. And then the nebulization can help break up mucus. And many of our patients who are hospitalized, we will use this in addition to the cough assist to help mobilize secretions. And there are a couple of small papers that showed some efficacy in small groups of patients with neuromuscular disease. And so we'll use it as a secondary agent. So some especially some groups in Europe feel quite strongly about using it as a primary mode of airway clearance. And in the next slide, there's a cartoon documenting what is felt to happen with IPV. And then the airway model in the top part of the image is an airway with secretions. And one of the issues is that if you have secretions in the airway, it's more likely that you can have plugging, as is demonstrated in the top image. However, if you apply pressure to raise the lung volume, then you can re-recruit that airway. Then with the pressure oscillation and the addition of nebulization, you can help to mobilize that mucus by shaking it off the airway with the vibration, and then with the nebulization help to thin the mucus a little bit and make it easier to clear. So I think that's my last slide in this phase of the talk, and turn things over to Dr. Schell for the next phase in the talk.
Thanks. I'm also very happy to be part of this. I was asked to talk about emergency care, which I think that you'll see as all three of us talk that there's a lot of repeat through all of this, but I've learned in my life that repeating is good. So I really wanted to start emergencies happen, and I think the best thing that we can do is be prepared for the worst, and hopefully that worst will never happen. But again, the use of prevention to prevent the complications, so to be proactive with the different doctors that you see during an emergency care or a surgery is the best approach. I always recommend having all of the physicians' names and numbers available, because if you're on vacation or you live in a smaller town that has less larger hospitals and things like that, that you have those doctors' numbers available that the people taking care of you can call and get assistance from. And again, I've had a couple of problems with some patients, and I always remind people that it's important to let these doctors know what your son or daughter has, to make sure that they really understand this whole process of having a neuromuscular disease. And there's been a couple times where I've had patients that, they forgot to tell their doctors that they actually had a neuromuscular disease. But I think that it's also important that there are routine things that you do in your everyday care that are very important to let these doctors and nurses and other caregivers know that may be routine to you but may make a huge difference in an emergency situation. Examples like your child uses BiPAP at night, or your child is on a cardiac medicine that they really need to know about. So breathing emergencies are what we're really focusing on, and oxygen is, I think, the hottest topic. I know there's been a couple of blogs on the PPMD about this, and we talk about this all the time. And my first point is that oxygen should not be used without checking or monitoring for other things that can go wrong during oxygen use. And the caveat to this is that oxygen is good. We all breathe oxygen. We all take that for granted. But in a patient who has neuromuscular disease who is sick, it's very important that without close monitoring, that oxygen should not be used as a first line of defense. If it's needed, it absolutely needs to be used whenever it's needed. But as long as they're using it and doing things to try to get the patient off the oxygen at the same time, I think that's the important point that I'm trying to make. We try to follow the carbon dioxide levels, the bad gas, because when you breathe shallow and you start a person on oxygen, sometimes that carbon dioxide level can go up higher, and that tells that sends different signals to the brain that we don't want to happen. I always remind people that if they do use non-invasive ventilation at night, when they are in an emergency situation and people are having trouble, even if you don't normally use this type of device during the daytime, it may be the best effective treatment to use. And again, assisted coughing with either a cough assist or breath stacking or any technique that you do at home, increasing this during a breathing emergency is an important way to clear those secretions and help the patient breathe. So another place that we see the emergencies, though, with anesthesia, it could just be surgery. It could be a simple procedure. It could be a very significant procedure like having spinal surgery, or it could be an emergency situation where somebody needs to have be taken to the operating room emergently. And I think it's very important to take an active part in all parts of this whole procedure. So the preoperative time before the surgery, the intraoperative time, and the postoperative time. Sometimes the preoperative or the time before surgery in an emergency situation doesn't always happen as effectively as we can because it's all going so fast. But if you can take an active role in all parts of the surgery that I'm going to describe here, it should make everything go a lot more smoothly. You should always ask, too, that if you have enough time, many hospitals have a neuromuscular protocol that they can follow. that the anesthesiologists and the intensive care staff and sometimes other departments all play a huge role in that. So before surgery, a proactive approach is always best. It is probably very important to have your pulmonologist or cardiologist assess before surgery if that's possible. If this is a planned procedure, many times the anesthesiologist will ask that this assessment be done. So they're asking that to be done without you even asking. And it's also, I think, important to make sure you know your pulmonary and cardiology specialists for the most part, but sometimes you don't necessarily know the anesthesiologist, and some parents will feel much more comfortable meeting them, though sometimes this doesn't happen until right before going back to the operating room. From the standpoint of a pulmonary evaluation, you want to plan to have this prior to surgery. This should include pulmonary function testing if the patient is able to do that. It can be, you can involve oxygen and carbon dioxide testing, so measuring saturations. So in our pulmonary lab, we can also measure an end-tidal carbon dioxide just at rest to see if their carbon dioxide is elevated, and that's something that can be looked at. I think it's also important before any type of procedure to make sure that you have a nutritional evaluation, that you're healthy enough to go to surgery, and also to make sure that there's no misswallowing or aspiration. If your child is having trouble swallowing or feeling like they're choking, sometimes that can lead to the recurrent respiratory symptoms as they get older. And I think it's also important to make sure that you ask the physicians that you're seeing about what their risks are for going to surgery, which then brings us to a few more numbers. And these are basically from various studies that have been published in the literature. But with pulmonary function testing, and hopefully at most of the MDA clinics, we at least try to get pulmonary function tests in our patients that can do the maneuver every 6 months to a year based on the recommendations. But what we're looking at is the forced vital capacity, or the FVC, as the main number that we kind of follow along in patients with neuromuscular disease. And if this number is less than 50% of normal, it poses an increased risk of pulmonary complications when a patient is undergoing anesthesia. If that same number is less than 30, that poses a much higher risk. The other numbers that we look at are the peak cough flow. Being less than 270 liters per minute does pose an increased risk, and less than 160 liters per minute poses a higher risk. And then we also look at the inspiratory and expiratory pressures, but in the literature, looking at the maximal expiratory pressures of less than 60 pose an increased risk as well. And these numbers really are guidelines. These are what's been published, but I tried to present them here so that people have kind of a baseline to compare them to when you actually have your numbers done in the clinic, so that you can see where that stands and then be better informed as to what risk anesthesia or surgery may pose. Other preventative considerations, and this is where the repeat comes in, but using the assisted cough device or the breath stacking, any way to clear those secretions, I always recommend doing that on a daily basis so people are very used to doing it, and increasing that when needed for respiratory illness. If patients are on non-invasive ventilation already, I believe that it is important to use that at baseline, and then if you are going to have general anesthesia or going to be having any kind of medicine that causes you to breathe more shallow or go to sleep, then it's always important to use this while you're waking up. And again, to assess the swallow and nutritional status to make sure that we're not missing anything that could cause more respiratory compromise. During surgery, and this is pretty well documented, but you want to discuss with the anesthesiologist what type of sedation. In Duchenne muscular dystrophies, I believe it's important to ask for IV anesthesia if possible. It's very well known that succinylcholine is an absolute contraindication, and your anesthesiologist should not be using that, but it never hurts to remind them that, though they should know that. There's some evidence in the literature that inhaled anesthetics may also pose an increased risk in muscular dystrophy, so that's why I suggested that when you talk to the doctors that are helping your child to go to sleep, that you can request IV sedation if that's possible. There are many other medications that are safe, so again, a pre-discussion, if possible, is the best approach. And you can also discuss what type of ventilation will be used in the operating room. Our neuromuscular protocol suggests that when a patient is in the operating room, they will be intubated. The anesthesiologist will be managing the airway, and as soon as they are able to extubate them, they go on to non-invasive ventilation. If it's at all possible and it's a simple, quick procedure in the OR, sometimes the anesthesiologist will be willing to use non-invasive ventilation, especially if the patient is already on that at home. And then after surgery, again, using the BiPAP, if you're already on that, is a strong consideration until a patient is fully awake. It's important to discuss where recovery will take place. It's also important to discuss how soon we can get that airway clearance started and the oxygen off if the oxygen is needed. And again, optimizing the pain control afterwards will help a patient breathe better and cough more strongly. I wanted to make a small note on dental anesthesia because our dental colleagues do use anesthesia for some procedures. I always recommend that less is best. Inhaled nitrous oxide is safe in Duchenne, but if it can be done with local anesthetic, this is probably a better choice. And if nitrous is used, some dentists will do what we call an oxygen washout for 1 or 2 minutes afterwards, and this use of oxygen, I believe, is safe in Duchenne and should not be worried. It's basically washing out the gas that's causing your child to go to sleep. And again, just to reiterate the use of oxygen, oxygen is good. We all use it every day, and if a patient needs it, it is okay to use it. But at the same time, you want to provide all the therapies while the oxygen is in use to help lower that amount or get them to be able to remove it. And this does include the use of non-invasive ventilation. And again, we just want to continue to make sure that monitoring is essential during the use of oxygen. So from an emergency standpoint, I basically based a lot of these slides on the data that's out there and then the documentation that the PPMD has put together. They have an excellent emergency care I don't know if you want to call it a handout or a card that you can go to the website and download it, and has a lot of this information already on there in case that you find yourself in a situation where you don't know all the physicians that are taking care of your child. So with that, I will turn it over to our third part.
So I want to cover some of the more recent aspects that we are beginning to publish on, which is the aspect of sleep disorder breathing in our younger boys with Duchenne muscular dystrophy. I just want to reiterate a little bit of what has been said and through as we go through some of this. So we know that there's progressive decline with Duchenne's, and the important thing that we have learned over the years is that much of the respiratory decompensation is very insidious and very quiet in its onset. One of the most common questions that families ask us at early visits with children is, what should we be looking for? And I always tell them, don't look for anything. You're not going to stand over the bed or while he's awake or asleep and trying to examine things. And things are often so minimal in their daily incremental progression that they are hard to measure. And so some things are best left to the folks who have the right tools to measure, and which is why you come to a Duchenne center for your care. We know that the respiratory issues pose a major cause of morbidity and mortality, but there's been an interesting turn in the last decade that with the advent of improved respiratory support, that is less becoming such an issue. So with progressive muscle weakness, there is an element of nocturnal hypoventilation that comes in. What we mean by that is that initially you're going to have nighttime manifestations of respiratory insufficiency before it progresses to daytime. And the reasons for that are because the wakeful drive to breathe disappears with sleep onset. So what happens with respiratory muscle weakness? I've tried to sum this up where the left half of the slide talks about changes that occur in the lung tissue. And what we tend to see is with respiratory muscle weakness, you breathe a little shallow and then more and more shallow. And as a result, you move less air. If you move less air, you move less mucus. Mucus stagnates, and that's how more frequently than not, they present with recurrent respiratory infections, especially lower airways. Also, over time, especially if it's a neuromuscular disorder of early onset, for example, some of the congenital myopathies or SMA, often there is reduced development of the lung because they are less exposed to higher volumes of airflow, and as a result, what we call the compliance of the lung begins to change negatively. So the compliance, the easiest way for me to explain this is if you look at a sponge is very easy to move when it's dry, but not so when it's wet. And so you're looking at ease of displacement of the lung when we use the word compliance. On the right side is some of the thoracic changes that take place over time. And Dr. Mayer and I have an interest in some of the thoracic dystrophies, both related and unrelated to neuromuscular disease. And some of the things that we see are, changes in vertebral rightfulness or the, erectness of the patient. And we call these kyphosis and scoliosis, whether they're front to back or left to right, curvature changes of the spinal column. And these also influence the chest wall compliance, meaning your chest wall also starts becoming stiff if there are abnormal changes to the chest wall as a result of muscle weakness. And at the bottom, there is the cardiomyopathy component that is also associated or drives some of the worsening of respiratory insufficiency, because a heart that pumps normally and beats well is less likely to cause backing up of blood and hence fluid in the lung, which again converts the lung from its dry to its wet form. And what I mean by changes in ventilatory drive is more related to the fact that people become accustomed to living with higher carbon dioxide levels over time, and that also reduces their respiratory drive. So, when we look at predictors of hypoventilation, there is much in literature when it came to adult Duchenne pathology. And they talk about awake carbon dioxide levels being greater than 45 units being an indicator for the presence of nighttime hypoventilation. When we mean hypoventilation, we mean hypo meaning lower and ventilation meaning the exchange of air. When I always tell patients when we breathe, we do two things. You breathe in, you oxygenate. And when you breathe out, you get rid of the stale air, so you ventilate. So when we talk about vital capacity, we're talking about the maximum amount of air that you could move from your biggest, deepest inhalation to the maximal exhalation you could possibly perform. So if you were breathing normally at rest, you squeezed out all the air you could from the lung and you took your deepest breath, that would be a measure of your vital capacity. So typically, there is data that has looked at mortality, looking at some of these numbers. But again, Michel Touzon from Belgium, as Hank has mentioned, presented some interesting work in airway clearance therapies, and also demonstrated very nicely that a vital capacity of less than a little over half a liter was a sensitive predictor for daytime hypercapnia. As I mentioned earlier, the data in young boys with Duchenne is lacking, and that's largely because these are growing children, and therefore you tend to see a very different architecture to the curve when you look at their vital capacities over the years. The disease has not become that established, and therefore it becomes much more challenging to study younger boys. So the objective in our study here was to determine the prevalence of sleep disorder breathing in young boys with Duchenne muscular dystrophy. We wanted to definitely characterize it and also describe its relationship with pulmonary functions, because, again, much of the data that has been published looked at much more established forms and mature respiratory status declination in Duchenne muscular dystrophy. So this is a very busy slide. But a few things I will just have you focus on. The first point says it's a retrospective study. That means we went back and looked at data and we didn't go forward with it. We examined diagnostic sleep studies and pulmonary functions of our boys under 18 years of age. And we looked at all facets of their pulmonary functions that we normally typically perform over here, looked at their body mass index for their nutritional status, as well as looked at just the sleep architecture. That means, do they go through the normal stages of sleep? Are they very symptomatic from a history perspective? Do they have lots of broken sleep, like we are familiar with adults who have sleep apnea? So at our center, until some of this data became available to us, we had gone through a quality improvement project where we had said, let's take a look and see how many children we can screen for sleep-disordered breathing at about 10 to 11 years of age. This was done at a time before I came here. And certainly some of the other indications to make sure that the children were safe with a sleep study was to look at them before major surgeries. Other factors such as loss of ambulation, recent rapid weight gain, a history of disruptive sleep, and significant changes in lung function were also indicators and currently we still maintain these as indicators for doing sleep studies in our patients. Just a little bit of characterizing of sleep disorders. In general, we talk about apnea, which is a complete cessation of airflow, or a hypopnea, which is a partial reduction of airflow. I've also already mentioned hypoventilation being an inadequate tidal volume leading to elevation of carbon dioxide levels. Now, when we talk about apnea, it can be either obstructive, that means there is respiratory effort, but there is no airflow. So it's almost like you were to collapse your airway but still continue to try and breathe and overcome that resistance. In a central apnea, there is in a central apnea, there is absence of respiratory input to the muscles, and therefore the muscles there is no effort to breathe, and as a result, it's a relatively quiet process and you don't see much airflow. A mixed apnea is a combination of both of the above. Now, the similar principles apply when we talk about obstructive and central hypopneas, meaning we see reductions of airflow when either it may be obstructive or the entire effort to breathe goes down but doesn't go away completely, in which case we call it central. Now, these seem very clear-cut to you, but I can assure you when we actually look at sleep studies, it is not that clear-cut. This is an example of a 2-minute screen of a patient who has what we call central apnea. So in light purple, towards the middle third of the slide, you actually see respiratory effort, and then there is a pause in the what we call C thorax and C abdominal effort. So those are the belts over the chest and abdomen, and they clearly indicate lack of effort over there. As a result, the upper part of the middle third of the slide actually shows the words protect and therm on the left. Those are actually indicate channels for airflow, and you can actually see absence of airflow over there. Oh, that's very helpful. Thank you. Now, if we move to the next slide, you will see a more typical pattern of what we call obstructive, where the purple lines in the lower third still show you some respiratory effort, and scaling a few lines above that, you find the loss of airflow. And this is typically what we call an obstructive apnea. Now, I'm going to go back to the previous slide, and in the upper third of the study, you see all those black squiggly lines. Those are the EEG components, meaning the activity of the brain activity that we look at. And physically, in conjunction with the changes, with some red line changes right underneath it, these changes in amplitude of the EEG, you see the high frequency suddenly, the burst of black activity in the EEG lines, tell you the episodes where there's actual break in the continuity of sleep. So that is actually a momentary arousal. So you can see this patient through this page actually has distinctly 4 episodes of arousal, and then the fifth one right towards the right corner extending into what we call the next epoch. The same is true when you look at this one, where actually there is certainly an increased amplitude and arousal in the beginning of this, on the left side of the sleep study, exactly where the green arrow is. And if we move the arrow further up a little bit further, just past the second change in amplitude of the, a little further to the right, please, a little further, that is where you again see an episode of sleep, of break in continuity of sleep. Again, after the next apnea, you see a change and increased darkening of that effect. So these are episodes of what we call arousal in sleep that suggest what we call sleep fragmentation. Now, it was interesting to note, and I don't think I've added on to this, that only 17% of our abnormal studies, which I'll come to in a little bit, had a history suggestive that of concern for sleep. So all our boys were on steroids, and only the first sleep study was assessed for these patients, and we had to ensure that the pulmonary functions obtained were within 3 months of the study. So I'm going to skip through some of this, but we had over 110 boys, fairly young in age, and they were not very weak. As you can see, their lung functions were about 79.5%, give or take about 29%. And their BMIs, what we look at is how heavy they are for how tall they are, were not too high, but they were spread over a fairly reasonable range. Now, when we looked at our studies, a lot more of the boys had obstructive sleep apnea, and very few had hypoventilation, which was a surprise for us. I've grayed out the areas that were less relevant for this, but in the interest of time, what I want you to focus on is the OI and the OI REM. So we had a group of boys that in the second column that says no, the 40 boys did not have any evidence of sleep disorder breathing, no evidence of sleep apnea. And in the group that said wherein the sleep study was abnormal, which is those 70 boys, you can see that OI and REM went from 2.9 in the normal group to almost 14.5, plus or minus 17, which is pretty impressive for young boys. And the REM sleep really is dream sleep. The OI means obstructive index. This is the amount of obstructive events per hour of sleep during dream sleep. And the RDI, which is the sum total of both obstructive and central events, are in the lower half. On the right half of the slide, you can see, some data that Hank can allude to maybe later, is the progressive decline in pulmonary function with age. We see the vital capacity go down with age over time, which is not surprising. But the interesting aspect of our study was that there was a very strong and positive correlation between the obstructive index and the BMI of our patients. So, keeping our patients leaner is certainly going to be of value. So obstructive sleep apnea was the most common form of sleep disorder breathing in our patients, and we were surprised to see it at a younger age. Interestingly, there was a strong correlation with weight. Just some basic relationships. We know that that the chest wall is conformed of 12 pairs of ribs that are married to a group of vertebral bodies at the back. And when they join together, they actually form a rather flexible rib cage that actually distorts with respiratory movements. So when you breathe in, your diaphragm moves down, and that's what draws air into the lungs, much similar to what a syringe does when you pull the plunger in. The process of breathing out is a fairly relaxed process by which everything comes back together by virtue of recoil, and that is what causes air to exhale. So typically we burn calories breathing in. And so when you take a breath, you don't realize it, but you displace your chest in 3 dimensions. We saw the diaphragm move down, but we also have front to back and left to right changes in chest wall measurement. And what changes when you go recumbent is, the orange arrow on the left half of the study suggests the direction of gravity. So gravity pulls all the bowel contents down, and that causes the chest movements to be rather unimpeded. When you move supine and you lay on your back, the bowel contents push the diaphragm and move it to a higher resting position. As a result, lung volume decreases. Adult data suggests to us that we have a 5 to 20% reduction in lung volume when you move from a vertical to a recumbent position with sleep. This is only amplified when you have muscle weakness, which cannot counter some of the abdominal forces. These are X-rays taken of a couple of our patients. One is a 12-year-old who had 100% respiratory muscle strength, and you can see the horizontal axis in red that I've drawn for the rib. And at 10 years of age, in another patient who had 75% muscle strength, you see a marked reduction in the angle of the ribs. So when we look at some of these images, we've begun to use these images to tell us whether or not someone may be at additional risk. What this image is telling us is a loss of flexibility of the chest wall, because this is not someone who can keep his ribs up and maintain optimal lung volume, particularly in the recumbent position. And sure enough, this is someone who had 75% muscle strength who actually landed up on BiPAP because of his sleep study. This is another patient of ours who you can see the same X-ray, 2008 to 2011. There was a progression in the decline of the angle of the ribs. And so we've actually begun to see quite a few of these changes take place, and these have begun to trigger how we think about the children with Duchenne. Respiratory muscle strength and lung function tests are measured instantaneously and do not truly represent what happens on a breath-to-breath moment for these children. So, with potential respiratory muscle weakness, there is sometimes predisposition to some form of thoracic dystrophy, what we call or thoracic wall changes. It can lead to diaphragm dysfunction if it is not already an independent contributor to the disease. With diaphragm dysfunction, there will be some impairment of the cough, and as a result, there will be some fatigue, impaired cough, recurrent infections, and then breathing is shallower and faster, and often becomes somewhat of a downward spiral for patients. I think cough mobilization of secretions has already been well covered. The only thing I want to emphasize is maintain good hydration, because thick mucus is hard to move. Looser it is, the better, and much more easy it is to clear. The new natural history of Duchenne has to be written with the use of steroids. The cardiorespiratory interactions we feel need to be better understood, and we should, I think, continue to look for better indicators for who really does and does not need a sleep study. But I think so far the chest X-ray is proving to be a better tool, at least in my experience, than lung function. I think we can open up for any questions, and thank you for this opportunity.
I think first Hank wanted to review the spirometry slides.
Yeah. So I have a couple of slides that I wanted to put out that come from some data that we collected here in our Duchenne population. And what the slides are meant to demonstrate is how vital capacity, which, as was described earlier, is a representation of how much air you can conceivably get into and out of your lungs when you breathe in as deeply as you can and out as hard as you can. And while it's not a precise measurement of a deficiency in any particular part of the respiratory, the act of breathing, it does involve both, obviously, your inspiratory muscles and your expiratory muscles. And so, irrespective of what type of neuromuscular condition you have, it can be very helpful in documenting change. And in Duchenne muscular dystrophy, there are a series of different phases that we often see. And if we focus on the left two images, it's forced vital capacity just as in terms of the volume of air that the patient can breathe in and breathe out. All of the data points are represented up top, in which you can see a general trend that's more easily seen if the data is presented as mean and standard deviation, which is towards the bottom left. And what you can kind of see is through the first 4 data points, which goes up to about 11 years of age, boys with muscular dystrophy had a normal increase in lung function, in vital capacity. That increase starts to slow down at around 11 years of age, which usually falls within the range of when most boys or young men will lose the ability to ambulate. Then there's a phase where there's not a whole lot, if any, gain in vital capacity, which sort of goes from about 11 until about 16, and then from that point on, there is a progressive loss of vital capacity, which often is the cumulative effect of can be the cumulative effect of respiratory illnesses, but also, as Dr. Sawnani mentioned, changes in the chest wall and spine with progressive scoliosis. The right image shows what we also see, which is looking at vital capacity relative to normal, presented as what we call percent predicted. And if you look at the bottom image, what you can see is a progressive decline in vital capacity as percent predicted, which starts from the latter part of the first decade and goes down well through into adulthood. And so one of the questions that often comes is at what point along the way does vital capacity drop below a certain point where different interventions are needed? And Dr. Sawnani mentioned some data related to when sleep studies should be performed. And some will have agreed on certain levels that definitely indicate a need for a sleep study. I happen in my own practice to look both at the vital capacity, but also try and get a sense from clinical history of where things are. If you just go to the next slide, and this is how I kind of look at things. And this is the bottom right image on the previous slide with a straight line set up to represent how far from normal the patient's lung function has declined. And that often is helpful in giving a sense of where the patient is in disease progression. So that's what I wanted to say about vital capacity.
Thank you very much. So we have 2 brief questions if you have time to answer those. So Hank, the first question is, would intrapulmonary percussive ventilation be helpful for a child who couldn't tolerate BiPAP?
The simple answer is yes, it can be helpful. What I try very hard to do if there's a problem with tolerating the cough assist is sometimes start with pressures that are below what I think would be useful, allowing a patient to accommodate to the cough assist, and then increasing the pressures as tolerated at a later point. If that's just simply not possible, then absolutely IPV has potential to be very helpful.
So it might be an issue, or it might be a tool to use if they couldn't tolerate the cough assist, but not if they couldn't tolerate the BiPAP.
Did I say BiPAP? I meant to say cough assist. I apologize.
No, it's BiPAP.
Well, the two are not the same.
Right.
One device is used for airway clearance and is momentarily used, so you use it for brief periods of time like you would use the cough assist. The BiPAP is something that you would use for extended periods of time, like through the night. And children with autism are, even in the non-neuromuscular population, we all struggle with this. If the sensory issues are a big problem, then certainly going through this, we have a desensitization process that we use at our institute. I'm sure most major institutes incorporate one. Children are not small adults, and so what we recommend is initially you wear the mask with nothing else attached for maybe half an hour, 15 minutes, twice a day, thrice a day, and then gradually you combine those brief periods of time and you build it into a longer period of time. And then you start with a low pressure while awake. All this is while awake, like when they're watching TV or on the computer, and they can kind of learn to tune it out. But once they're able to tune it out for half an hour or so, or an hour, then we take it to the bedtime and we start doing that process every night and then take it off after that. Eventually, our hope is that they will begin to wear it longer and longer. Once they're able to wear it up to 2 hours, then we usually get them into the sleep lab and we tweak their pressures and go from there. But children with autism are, unfortunately, a huge challenge for us.
Okay, thank you very much. Richard, can you speak to the differences between BiPAP and CPAP that often gets confused, and especially in emergent situations?
Yeah, I saw that question, and it's a good point. At least I believe CPAP is not, and I've learned this from my sleep colleagues, but in neuromuscular disease, the difference between CPAP and BiPAP, CPAP is just a constant air kind of being blown at you. It is good for the obstructed type of problems that people have at night. With muscular dystrophy, since it's a neuromuscular weakness and the muscles are weaker, it's BiPAP. So BiPAP is a biphasic setting where you have an inspiratory pressure and an expiratory pressure, kind of like the cophasis, but it lasts for the whole night or how long you're using it. So every time a patient takes a breath in, you get help breathing that in. So BiPAP is much more appropriate for children with neuromuscular disease in an emergency situation or in a situation where they actually need it at night, and that's what we sometimes use the sleep study to help well, I shouldn't say sometimes. We use the sleep study to help determine when the best time to start that is. Hopefully that explains that a little bit.
Can I add something to this?
Yeah.
We've had some patients who've been started on support from other places come to us, and so I find interesting aspects to the settings when they bring their machines. So, as Dr. Shah explained, there is a pressure that allows, normally when we breathe out, we don't breathe out to zero pressure in the airway. You need a certain amount of airway pressure to keep it open. Similar to like if you took a balloon and just popped it, inflated just enough to pop it open so that the walls didn't stick together. That's what CPAP would do. Now that runs in the background, so the way we look at it is that facilitates exhalation. But you need a driving pressure to support taking a breath, because very often these patients breathe really shallow in sleep. So you want to deepen that breath, so you need to add support. And when the body gets an augmented breath or a bigger breath, it thinks, oh wow, I don't need to add any effort. And then all of a sudden these children quit breathing entirely. So there has to be a backup rate added to this BiPAP. It can't be just what we call an S mode, which is synchronized mode. It has to be an S/T, meaning synchronized or time mode, so that if the patient does not breathe adequately, like as would likely happen in dream sleep, rather than non-dream sleep early, then at least the backup rate kicks in and they continue to benefit from good airflow and oxygenation and ventilation.
Thanks
for adding that. That is definitely an important part.
One final question for Hank. We know from Duchenne Connect that only about 37% of ambulatory boys have received pulmonary function testing or spirometry. Could you speak to why that's important?
Well, I think it's important because it's a fairly simple and I think fairly useful measure of progression of respiratory disease and muscular dystrophy, and that's been at least my thought for many years, and I think many share that. And there was a recent paper that came out a couple of years ago by Brigitte Farreau and her group in Paris, looking at least in my opinion, pretty much every possible muscle and lung function outcome that people will look at in muscular dystrophy. and looking at it over time and looking at progression of disease. And what really was found to be really the most helpful in reflecting change over time was, as I recall, maximum inspiratory pressure, which is a common measurement that we make, but also vital capacity. And so because it's so simple to do, I really feel that it's an exceptionally important and useful measure to follow. And it really is a summative measure that, as I mentioned before, reflects both your ability to breathe in deeply and then breathe out as deeply as possible. And I think it's absolutely critical to have that as a measurement to follow.
Thank you. I'd like to take this opportunity just to thank our presenters. This has been fascinating. If you have questions, my email is on this slide, and I'll be sure to pass them along to the experts. This concludes our webinar. Thank you very much.